Hello and welcome to the July meeting for the Rural HPV Vaccination Learning Community. On behalf of the American Cancer Society and the National HPV Vaccination Roundtable, I want to thank you for joining and taking time out of your busy schedules, whether that's live or via recording in the future. We will be offering live CME and CNE credits for today's session. So today we're going to be kicking off our summer communication series by covering effective communication styles for HPV prevention. I do want to note this program is supported by a grant from the Centers for Disease Control and Prevention of the U.S. Department of Health and Human Services. If you want to go to the next slide. So I'm Ashley Locke, HPV Program Manager at the American Cancer Society. I'm joined by my colleagues Hannah Nine, Kayla Monslitze, and Christina Turpin, who also work on our HPV vaccination team. Next slide. So as we officially kick off summer here, what plans do you have in place for increasing HPV vaccination with back to school efforts? So go ahead and type into the chat and share with us what you plan to do. I'll give it a minute or so. Would love to see some answers in the chat. So Sarah says she's going to increase social media. That's wonderful. Send out emails to school staff and write an article for the local newspaper. That's very exciting. That's another Sarah. Tracy says we're handing all parents who bring their patients 9 years to the doctor for the HPV VIS sheet and also doing some social media posts. Very exciting. Angela shared multi-county back-to-school communication and education campaign, including billboards and social media. That's very exciting as well. Amanda, we're offering the vaccine in our back-to-school clinics for incoming 7th graders. That's great, Amanda. Wonderful to hear. Taya, I'll be attending 7th grade registration at local middle school to do offsite clinics. Very exciting. Athena, going to local schools with the medical provider I work with and discussing HPV vaccine and telling my cervical cancer survivor story. Perfect. Thank you, Athena, for sharing. Kelsey is going to host back to school vaccine clinics this summer and include promotion in our monthly school newsletter and promote on Facebook. Very exciting. Daniel says back to school, a back to school drive with free backpacks and HPV education. Nico says she's going to be working with CHDs as they have back to school clinics. Katie mentioned planning a back to school nights and offering vaccines. So perfect. Thank you. Feel free to keep continuing to add to the chat. These are really great ideas and we appreciate you participating and sharing. For those who said social media, stay till the end of the call because we have a really great resource for you all that we'll be sharing. If you want to go to the next slide, perfect. So we have another jam-packed agenda for you. So in just a minute, we're going to quickly review a few items from our June session, and then you're going to hear a personal story of strength from Kim McClellan, who's the president at the Recurrent Respiratory Papillomatosis Foundation. Following, we'll hear from Dr. Jessica Reggie, who will talk through different communication styles for increasing HPV vaccination. And then we're going to close out with a Q&A with Dr. Reggie and Kim. So before we do so, I do want to share a couple of reminders. All our rural HPV vaccination learning community sessions are recorded and posted to a public-facing website. So please turn off your camera if you don't want your image recorded. This session is certified for live CME and CNE credits. We've added a link to the chat detailing out that information for today's session. I do want to note that Kim does have something to disclose. She has contracted research with Merck. However, none of our other planners or speakers have anything to disclose. And then we ask all participants to stay muted until our Q&A. However, our chat is open for questions and support. Next slide. So for today's session, we'll be focused on the following learning objective, discussing evidence-based communication strategies to effectively discuss the HPV vaccine with different audiences, including parents, adolescents, and healthcare professionals. Next slide. So before we get into the session, we are going to do a quick poll and ask that you tell us how confident you are with the different communication styles. So give you guys a little bit of time to answer. Looks like we're slowly getting some answers in. Perfect. All right. So we've got 20% who've participated so far. Seems like when it comes to the presumptive and announcement approach, the majority say they feel somewhat confident or confident. Both are similar. And when it comes to motivational interviewing, we have slightly confident as the winner so far. And then the current practice and which style you use to recommend the HPV vaccine. Seems like everyone uses a mix of both, which is exciting to see. Just give it a little bit more time really quickly so we can get a few more answers in. Appreciate those that have already participated, so thank you. All right, for the interest of time, we'll go ahead and end the poll. Quickly share out the results. Like I said, it looks like somewhat confident and confident come first when it comes to the presumptive and announcement approach. Slightly confident for motivational interviewing. It seems like most use a mix of both presumptive approach and motivational interviewing. So very exciting to see. Thank you once again for participating and sharing with us. If you want to go to the next slide. So I'm just going to quickly review some of our information that we shared in the June session before I move it over to Kim. So if you want to go to the next slide. So this slide just kind of shares a little bit about evidence-based interventions and the different buckets that we have. So just to kind of ground ourselves, evidence-based interventions, also known as EBIs, are proven methods for prevention or treatment backed by peer-reviewed research that significantly elevate our outcomes. And there are three buckets: patient-directed, provider-directed, and increasing community access. We know that interventions are best when done in combination, and today we're going to spend some time talking about the three different buckets of interventions quickly. So if you want to go to the next slide. So this slide in particular details out evidence-based interventions proven to increase vaccinations, including the HPV vaccine. This slide does not encompass all the interventions that we discussed last month, but highlights some of the big ones. If you didn't join us for June, I'd highly suggest you listen to our recording, and I'm going to have Kayla actually link it in the chat for you, so you can go back and listen to it. But specifically for patient-directed interventions, there's reminders, one-on-one education, small media, which includes posters, social media, and others, patient incentive like vouchers, and waiving administrative fees. For provider-directed interventions, there's the EMR and EHR enhancements, provider assessment and feedback, which we also know as report cards, standing orders, professional education, and provider reminder and recall systems. And lastly, to build community access, the interventions include reducing structural barriers. That includes, having mobile clinics, adding vaccines to support physicals, having school-based clinics, and then reducing out-of-pocket costs. So providing transportation vouchers or waiving, administrative fees. And then there's also providing patient navigation to address social determinants of health. If you want to go to the next slide. So once you've obviously completed your capacity building discovery phase to see what's going to work best for your clinic or system, it's time to then identify interventions. So we talked about this worksheet last time, but it's a template and it's a great tool to use with your QI teams and staff to really lay out all the interventions that everyone wants to see implemented. And then you can really start asking questions. Does this intervention align with our goal? Do we have resources to implement the intervention? Will our care members be supportive and engaged? And how will we test success? And so once you've gone through that process, you'll start to eliminate interventions that aren't going to be feasible. And I said this last month, but don't completely toss out ideas, but keep them on a dream board. You can always refer back to them and consider the intervention in the future. You may find out when you test out an intervention, it doesn't work. So having backup ideas is always a best practice. And then next slide, just to sum up a few reminders about evidence-based interventions. Once again, they're best when done in combination. Make sure to choose interventions that align with your goals and will solve problems. Make sure to map out and integrate your interventions so you know how they'll fit within your workflows and processes. You don't need to reinvent the wheel. Our June session gives you so many ideas, so please watch that recording and then also follow along in the chat. Many have added some really great ideas as well. And then most importantly, make sure you're getting consensus from your fellow QI team members before implementing any evidence-based interventions in your system. It's important for everyone's voices and ideas to be heard. This really helps with buy-in. So next slide. So without further ado, and after we've reviewed our EBIs, it's time to hear from Kim McClellan. So in 1971, at the age of 5, Kim was diagnosed with recurrent respiratory papillomatosis, or RRP for short. It's a rare disease that left her barely able to speak or struggling to even breathe. After decades of surgery and ultimately getting a trach, Kim regained her voice. Now, as the president of the Recurrent Respiratory Papillomatosis Foundation, a patient advocacy organization, she is using her voice to fight for recognition, treatment options, and hope for all RRP patients and their families. So we have included a link to the RRP Foundation and a way to connect with Kim. Kim, please take it away.
Thank you. The title, you see, RRP, we should talk. I hope by the end of this short story that you'll know a little bit more about RRP, a little bit more about my journey and the patient journey, as well as why HPV 6 and HPV 11 are a big deal, and the fact that we can dream about eradication. Next. So just to give you a little bit of background on what recurrent respiratory papillomatosis is, as we said, it's a rare disease caused by HPV 6 and HPV 11. Right now, the only approved treatment method is surgery. I've had over 250. We have patients that have had double and triple that. RRP also has a cancer component, which I know most people don't know about. About 8% of us will have what's called pulmonary spread of the disease. Of those 8%, about half of us will go on to have malignancy. And from there, it has a very high mortality rate. So when I say let's talk about it, we're the HPV disease that no one's talking about. And I'm so grateful to be here today to change that conversation as quickly as we can. Next. I want to tell you a little bit about my story. I was diagnosed when I was 5. After about a year of being told that I had asthma, upper respiratory infections, all the things you would naturally think of as a pediatrician. Once diagnosed, my parents were told that when I hit puberty, the disease would go away. We now know that's not true. So over 250 surgeries later, tracheotomy for over 30 years, I'm still basically being treated the exact same way I was in 1971. surgery after surgery. There are some off-label therapies being used. I'm on one of those, and it has given me a reprieve from the OR, for which I'm very thankful, because none of us is equipped for dozens of surgeries, much less hundreds. No one's equipped to watch a loved one go back to the OR dozens, hundreds of times, no matter if they're a child or an adult. We're used to someone having surgery, they recover, and life goes on. With the RP, that's simply not the case. I'm very happy to report that things may be changing. We have two companies that are pursuing FDA approval for therapeutic treatment that does seem to work in a good many of patients. Ashley mentioned finding my voice, and the story there is for over 20 years, my voice was nothing more than a whisper. My son, who's now 31, had never heard me read him a bedtime story. About 7 years ago, I had a surgery, and for reasons I do not know, this voice came out. And it was there that I asked God to use this voice for as long as I had it. Just a few short months later, I was asked to take over the foundation. Suddenly, the thing I wished more than anything would go away was going to become my purpose. So I was voiceless, finding a voice. My story is not unlike many of the RP warriors. Matter of fact, I saw a name on this meeting today who's also a warrior. We share the same fears. Share the same concerns about going into a social situation and simply not talking because no one can hear us. We also share that warrior spirit of realizing that unless we come together and join our voices to become one loud voice, no one's going to hear us. And that's why we have to be loud as one community. Because HPV 6 and HPV 11, they are a big deal. This disease is a big deal. Some of the places that I've been able to go as I found the voice that's become the voice of an entire community. I was asked to go to the White House. Remember, over 20 years, my voice was nothing more than a whisper. And I was sitting on the grounds of the White House talking about the RRP story. I was asked to be on the survivor panel at the HPV meeting this spring, sitting on the stage with literally rock stars in HPV cancer, realizing that RRP had found a way to be at the table with the HPV cancers, something I had dreamed of. Next, more importantly, as I gained my voice and the patients gained their voice, I noticed what my why was. I found my why, and it's the patients. I am so fortunate to be in a situation where I am able to do what I'm doing. For those of you that don't know, I mean, I'm a volunteer, just like so many in the HPV space. But I've been able to take my journey, the journey where my parents were told the disease would go away, the journey where my parents were told there'd be a cure within a decade, the journey where my own children watched me almost die from a surgical mistake. because of RIP. The frustration that I get to deal with when I do something as simple as go through a drive-through and try to place an order. The patients are my why. I can't change my story, but I can do everything in my power to help make sure that my story doesn't become their story. And that's my why. So that those children and adults diagnosed today don't have 250 surgeries, don't have a tracheotomy, and they don't have that feeling of no hope, because everything I do is to make sure they know that hope is real, change is coming, and tomorrow is going to be so much better than my journey was. But for those on this call today, when we talk about HPV vaccination, I think about Australia. Since 2019, they have had no cases of juvenile onset to mothers who were vaccinated. We have the power to eradicate this disease. And that's why the foundation and myself put so much effort into the HPV vaccine message, and why we are here to say we matter, and we're so grateful to be at the table now. Thank you. One last thing, I'll go back to the last slide. I'm sorry. I got caught up as I do, but I just wanted to end with this when I talk about it being a big deal. 89% of those patients who responded to our patient registry limit participation in social events. 45% of them suffer from depression from all of the surgeries, but only 24% utilize mental health services. I know we see the same in HPV cancers, but look at the quality of life. In spite of everything, life is good. And that's what I hope you carry from this, is that this is a community of warriors who are not going to let the disease stop them. Just like I'm not going to let having a voice that society calls not a voice stop me from making change, change that matters to our community. Next. But thank you so much. If you have any questions, I'm available. You can email me. And I'm proud to say that the foundation is a Chan Zuckerberg Initiative Rare as One organization. And much of what we do is because of their support. Thank you.
Thank you, Kim, so much for sharing your story with us. You are so incredibly inspiring. And if you have any questions for Kim, we will have a Q&A at the end of the session. So please feel free to type them into the chat. But I'm going to now turn it over to Jessica Reggie, who is a board certified pediatrician and school subject health subject matter expert. So we'll post Dr. Reggie's full biography in the chat and a way to connect with her directly. But go ahead, Dr. Reggie.
Thank you so much, Ashley, and everyone for having me today. And thank you, Kim, for sharing your story. Next slide. So today we're going to talk about a few strategies for HPV prevention, whether you're communicating in an urban or rural setting, whether or not you are talking with patients, their caregivers or family members, or other staff that you may work with. Next slide. So we know that communication skills are a core competency for healthcare professionals and health champions. We're trusted members of the community. And the best predictor of HPV vaccination uptake for both hesitant and non-hesitant parents and caregivers was how that conversation started. So we know that how we talk to parents impacts their opinions and behaviors on vaccines. So for HPV, we're going to talk about some interventions and tailored communication skills that have been proven to increase vaccination rates. Next slide. So I know you are all familiar with this, but I just wanted to revisit it here and reiterate that on-time vaccination is considered from ages 9 to 12, and late would be at any point after that. So that's why starting these communication strategies, starting the conversation at age 9 is so crucial, as opposed to waiting, how like we have done in the past, closer to that 11-year-old well-child checkup. Next slide. So when we talk about the HPV vaccination, we always want to lead with cancer prevention. HPV is very common, so it's far more important to talk about the cancer prevention component as opposed to how it's spread and its transmission. We know that cancer prevention is a strong motivator for any patient, for any family member. It's also important to normalize the HPV vaccine. In today's world, it's easy to get caught up on an anti-vaxxer story or a sensationalized media story, when in reality, most families are choosing to vaccinate their children against HPV. We'll talk about starting with that announcement or presumptive approach that I know you were introduced to last month, but that is always, the place to start. And when doing that, you want to prioritize connecting with empathy, giving non-judgmental advice, and then even sharing real stories about the risks of not vaccinating. The goal of any conversation about the HPV vaccine is action. So whether that's vaccinating at that visit or coming up with a follow-up plan that everyone feels confident in. Next slide. So for the announcement approach, we're going to use direct statements, just the facts, and be quick and fast. Next slide. So as a review, that's using a presumptive, persuasive statement, that strong provider recommendation. You can announce the age of the child or patient, center the conversation on cancer prevention, use the date, mention that the vaccine will be given today, and if you will be doing other vaccines at this visit, you can bundle it with the Tdap or meningitis vaccines, or maybe it's during flu season and you'll be giving the flu vaccine. But essentially, you are using this approach to convey that the HPV vaccine is just like every other vaccine. Next slide. So at a 9 or 10-year-old checkup, it might sound like this. Your child is 9 years old, which means today he'll get his first dose of the HPV vaccine, and we'll do this at the end of the appointment today. This is a vaccine that protects your child against 6 types of cancer. Next slide. In a slightly older child, this might look like your daughter is 11 years old, and today she'll need 3 vaccines to protect against meningitis, HPV-related cancers and diseases, whooping cough, and tetanus. She'll get those at the end of this visit today. So grouping those vaccines together shows that they're all equally important and communicates to the parent that the HPV vaccine is not different or inferior to any of the others that you've just mentioned. Next slide. So a few reminders. It's always important to center that we have the patient's best interests at heart. All parents and providers want to protect that child's health. And most parents value the HPV vaccine. They are likely to accept the announcement approach without question or concern. So don't go into that conversation expecting pushback. You can always start with that strong provider recommendation of the presumptive approach. Next slide. Now we're going to move into motivational interviewing, which is a collaborative conversation style for strengthening a person's own motivation and commitment to change. It's a more open-ended conversation between provider, and parent or patient. Next slide. So where does it fit in? Parents with hesitation, questions, and concerns. So if we take a look at the flow sheet, again, we always start with that strong provider recommendation. And then if there are questions, concerns, or issues that come up, that's when we're going to implement motivational interviewing skills. So the primary goal of motivational interviewing is to interact with that patient, that parent, that staff member in a way that increases their own motivation to change. And then ideally, you'll hear more change talk, which is really anything they say that may indicate a desire to change their behavior and move forward. So it can be really easy when we're talking about motivational interviewing to get caught up in the approach, different techniques, acronyms, different phrasing. So I want to reiterate that it's not necessarily about steps or techniques. It's really about the right mindset or heart set. And that's coming from a place of partnership or collaboration in that patient provider relationship, non judgmental acceptance of that family and their viewpoints, a compassionate approach in which you are talking to that parent to evoke their strengths and resources. Next slide. So before we get into motivational interviewing, we can take a minute to just think about any hesitancy around the HPV vaccine. So here you'll see a handful of some of the more common reasons for vaccine hesitancy that we come across. You're welcome to add additional ones in the chat so we can all learn from each other. But I'll just review a few here. So definitely we hear a lot about vaccine ingredient safety, pain from this particular vaccine, of course, concern about sexual activity and fostering sexual promiscuity, gender or age questions, the concern about giving multiple vaccines at once, particularly at that 11-year-old checkup. Many patients and families often tell us that, another provider did not actually make that strong recommendation, so they have questions around it. And then especially today in our social media world and the current political landscape, we have a lot of misinformation and disinformation circulating. So parents may have read that or consumed that media in some way and come in with lots of questions. And I want to just mention that the American Academy of Pediatrics just put out an article earlier this month called How Pediatricians and Providers Can Teach Parents to Resist and Recognize Vaccine Misinformation. So it kind of highlights strategies that those who spread misinformation and disinformation may use in their writing or their messaging, and then talks about effective communication strategies to use when talking about the HPV vaccine or other vaccines. And it definitely highlights the methods we're talking about today. So we'll share that with you all as well. Next slide. So in getting into motivational interviewing, there are 4 umbrella processes. The first one, next slide, is engaging. So this is clearly that process of establishing a trusting, collaborative, mutually respectful relationship with the family so that you can come to that shared decision making and agree on treatment goals. Next slide. So to start building that relationship, we can focus on this acronym called OARS. So our goal is to understand where the parent or the patient is coming from and what they're bringing to this conversation. And this stands for open-ended questions, affirmations, reflection, and summarizing. Next slide. So first, we're going to talk about open-ended questions, which we use all the time. They are difficult to answer with a yes or a no, so they allow for a fuller, richer discussion. It's a conversation starter or opener that allows the person to talk with their own language, in their own lingo, and thereby keeps the conversation focused on them as opposed to us as the questioner. So if you think back, like over the past few days or the past weekend, I'm sure we can come up with an open-ended question, that we may have used. And it's not always in a clinical setting, right? So it can be something that you ask your child to elicit more information about their day, or something you may ask a staff member to get them to reflect on a situation. So just thinking about how those open-ended questions foster relationship building and leave space for more questions and conversation. Next slide. Affirmations are things we do all the time and probably don't even notice we're doing them, like saying yes, nodding, making eye contact. So they are statements or gestures that recognize a person's strength, build confidence, and lead that person in the direction of positive change. It's important that they feel genuine and that they match that person's energy and attitude for that conversation. So that can sound like, I know you've done a lot of research on this topic, and I appreciate that. Or I understand that you absolutely have your child's best interests in mind. Next slide. Reflection is really two-part. So you are doing reflective listening and thereby allowing that person, that parent or caregiver, to keep talking, keep thinking, and you're showing that you are listening and there to reflect back to them what you are hearing and talk it through. So it allows that parent or caregiver to maybe even express feelings or voice concerns and thoughts that may have never said before. It helps them feel understood and accepted non-judgmentally. Next slide. And then finally, summarizing exactly what it sounds like. We are recalling that conversation from start to finish in the hopes of maybe thinking of some new ideas or transitioning from one theme to the next, maybe moving from one question into another, or maybe moving from the discussion to planning the next steps, whether that's vaccinating or a more in-depth follow-up plan. But the idea is to create that confidence in moving forward. So these techniques, ORs, open-ended questions, affirmations, reflection, and summarizing, are really helpful for that engaging relationship building, but can be used throughout the conversation. Next slide. The next process we'll talk about is focusing. Next slide. And this is really where you're eliciting the main issue, the main concern, the main question, or the parent's main source of hesitancy. So, is this a question about ingredient safety? Is this coming up from misinformation or disinformation they've read, or a clip they may have seen on social media? It helps you focus on what the parent really wants to learn or needs to get out of this conversation so that you both don't go off in a side direction or a tangent. So it's an ongoing process of seeking and maintaining a forward moving direction to get to that action planning. Next, we're going to talk about evoking next. This is also really a two-part process. You're trying to determine how important this issue is to the parent and the family and how confident they feel about making a change. So maybe they do feel like HPV vaccination and HPV related cancers are serious and the vaccine's important, but they're not yet confident to make that change. So we still aren't going to see that yes or that action to vaccinate. Next slide. So again, it's the importance to them, to the patient and the caregiver, of making that change and how confident they are to move forward. Next. And then the final step we're going to talk about, this last process, is really just the planning. Next step, or next slide. In planning, we're really having them commit to moving forward. So sometimes that looks like vaccinating, and that's usually what you're going to see. And you'll be able to just move forward with, can I answer any other questions? We'll be vaccinating your daughter at the end of this visit today. Or it might be hearing them say or elicit more change talk in a forward moving direction, like you can hand them a resource, or maybe their partner will come to the next visit and you can have a conversation with both of them. But it's really just that next step. And next slide, please. If you're hearing that change talk, those comments like, you know what, do you have that VIS sheet? Someone mentioned that in the chat. That's a great next step or resource. Maybe it's just giving them that. It's, saying, awesome, I would love you to take this home and we'll talk about it at the next visit, or even scheduling a next visit for that exact reason to talk about it again. So as you're hearing this positive change talk, you can bring back those ORS techniques to support the conversation. So you can ask more open-ended questions about what the family may envision the next step being. You can affirm what the parent's saying, reflect and kind of loop back on some of those earlier comments, and then again, just summarize those positive change messages. Next slide. So after all of this, if you create that engaging relationship and you make space for all the processes involved in motivational interviewing and you're still getting a no, what do you do next? I think it's important to just maintain that non-judgmental, compassionate space and center the conversation and your own attitude moving forward on acknowledging that you both have the child's best interest at heart, even though that looks slightly different today. And for me, I always would end these conversations with the statement that I am going to bring this conversation up again. We are going to talk about this at the next visit, which to me sets the stage for just building that trusting relationship and setting the expectations that this is important for your child and it's an important decision for us to make together. Next slide. So just a few wrap-up comments. We want to always share first that the HPV vaccine is cancer prevention, and then go into further questions and answers, sticking to the facts, but always leading with cancer prevention and normalizing.
Hi, what'd you find?
And
What'd you
normalizing
find?
the HPV
Yummies?
vaccine, just like any other vaccine,
Num num?
grouping it like we talked about with the other 11-year-old checkup vaccines or the flu shot or a COVID booster. Starting with that announcement or presumptive approach and not expecting pushback or questions, leading with that confident, strong provider recommendation. And then using motivational interviewing to bolster conversations when that vaccine hesitancy does come up. You can always share your personal belief, personal and professional belief in that vaccine, and share what you've learned along your journey in, the HPV vaccine and your clinical career. And then always center the conversation at the end on action. So what is your next step? Are you scheduling a follow-up visit? Are you scheduling that second dose? Are you handing out information or recommending a resource? All right, thank you. I will hand it back to you, Ashley.
Thanks, Dr. Reggie. I'm going to wait just a second to get Kim back up here as well for some question answer. Feel free to put them in chat. I don't think I saw very many questions yet, but everyone is reacting with a lot of great things they've heard. And so I think that's very normalizing for all of us to hear that we're kind of hearing all the same things. So I'm going to start off with the first question for Kim. Kim, what do you wish more healthcare professionals understood about living with RRP?
Well, first, I would hope that after today, they understood that when they were told that 6 and 11 were the good ones to get, they're not the good ones to get. This is not good to get. And that would change their conversation with, with parents and saying, yes, 6 and 11 may not cause cancer, but it can cause this, and this would be what your child and future grandchild possibly be facing. I wish they knew that surgery isn't treatment. For so long, patients have just been told you have to have surgery over and over again. And I don't think anyone believes that is treatment, but that's what it's been allowed to be all this time. And, thankfully science is catching up and we're looking at possibly having that paradigm shift, which we're also excited about. But I just wish more clinicians understood what surgery really meant. That when they discharge that patient home, that's not the end of it for that patient or their family.
Yeah, it's great. As a parent, just hearing that you've had over 200 surgeries is just surgeries alone, but then the prep, the fear, the trauma of it, just all of that together is unfathomable. So I'm so appreciative that you're telling your story.
Well, I didn't share this, but as a child, I slapped a nurse and ran out of the pre-op holding. Um, that's the trauma that many surgeries cause as a child.
Yeah. Oh, yeah. Thank you for sharing this with all of us. I know for me, I was lucky enough to see you in Indianapolis in April, but I honestly, I'm a director for the National HPV Vaccination Roundtable, and I didn't know that much about RRP. So I'm very appreciative of you sharing your story with us.
Thank you for having me.
Yeah. Dr. Reggie, let's dive into a little bit of what you talked about. So a lot of people you can see in chat, a lot of the kind of hesitancy things they hear, so they feel unsure, uncomfortable addressing HPV vaccination hesitancy. Do you have any go-to advice or strategies that you could share to help build confidence or effectiveness, kind of addressing these hesitancies?
Sure. So I've been following along in the chat and I agree these are tough to hear and difficult to address because a lot of it centers on that more social emotional piece where, our tendency is to lean on science and share just the facts. So I think practice and just repeated experiences like this help build our confidence and then in turn help build the confidence that our patients and families have in us and our recommendation. So, one of the strategies that I always used was that access to care. So, anytime that a patient who is eligible for the HPV vaccine would be in the office, it would be offered and it would be a conversation in the clinic. It used to kind of be habit that if someone was there for ear pain, you were assessing, diagnosing, and treating an ear infection. But I think a lot of clinics, especially in rural settings or like a federally qualified health center in an urban setting, we're really leaning into that access to care and taking every opportunity to offer the vaccination, share information, and ideally vaccinate, whether they're there for that reason or not. And I think those conversations, because you repeat them time and time again, help build confidence. And even though these conversations are built on that more social emotional doubt and kind of like the sexual activity and the infertility and the relationship components, I still always lean on the scientific facts.
Yeah, that's great. I always like to, when you were doing the recap of saying that you're going to talk about it again. I feel like there's something reassuring in that, both for you as a provider and then as like a parent side of being like, okay, like if I need time to digest and think about things or do my own research, we'll have the conversation again. I think that's, and just kind of showing that it's important. Like you're going to keep having it because it's important to talk about. So I really appreciate that. So is there anything, Dr. Reggie, that you use that's a helpful resource or tool or anything that you've covered today in your work that you think others should know about for the future in their planning?
Sure. So I think third party validation is really helpful. So a tangible resource, I loved who said in the chat about handing that VIS out. Like just having someone else, whether it's the VIS sheet or like an American Academy of Pediatrics blog post, I really like having someone else share that messaging. So we're going to share with you a blog post that I wrote along with Healthier Generations manager of culturally responsive communications that lists some of my tried and true, like science and evidence-based third-party validation and just some tools for these conversations. I also think relying on partnerships, depending on where you're practicing and where these conversations are occurring, can be really important. So I know we've talked a lot in the chat about back to school events and on-site clinics. And I think having other health champions present, like whether that is a faith-based leader who is science-minded and like-minded, can kind of be there as part of the community, or whether it's the health department on site, but really just having those tangible resources and in hand, as well as the people that can offer that third-party validation alongside you.
Really good advice. And we do have resources coming. So at the end, and I think, oh, Ashley just shared the article as well. So thank you for that. Next question, Kim, I have for you. What is one way you want to see the participants today on this call help advocate for RRP and HPV vaccination?
I think in your practice, sharing about RRP to your parents and say there's this HPV disease called recurrent respiratory papillomatosis, which I know it's a mouthful. It is. That you can also prevent not only your child possibly being an adult onset, but more importantly, you can prevent your grandchildren from having this disease. And this disease grows in the airway, and you have hundreds of surgeries. Right now, surgery is the only treatment. And no child does anything to get this disease. So it kind of removes that, well, my child's not going to do X, Y, Z, because the child, me as a 5-year-old, I didn't do anything to get this disease. It's HPV disease that was passed in utero from my mother to me. And it could have been prevented had the HPV vaccine been around in the 60s. So that's my message to doctors, is just the more we can share about this other HPV disease. And I know in the US we have to be careful because, we don't have the indication yet, blah, 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 but we can't tell them about the disease, that it is an HPV 6, HPV 11, and those are two types of protection you get in the HPV vaccine. So I think the more we tell people it exists, and it's a conversation that takes sex out of the conversation. So my hope is it gets some people off the fence.
Yeah, that would be great to spread. And I think hearing your story and the passion behind it has helped everyone get a little more confidence today talking about it. So thank you. And then I guess final moment, Dr. Reggie, anything last words you want to share for this group? Any kind of advice or confidence builds just to leave them with before we move into our wrap up?
Sure. The presumptive approach absolutely works. And when I have used it, I think it's really important to work it into your like clinic or conversational workflow. So at the 11-year-old checkups, I used to sandwich it between like you are due for meningitis, HPV, and Tdap. And just like we talked about earlier today, you want it to sound exactly like the rest of the vaccines and really not instill any question or hesitancy in that conversation. So, just make it part of your routine, make it part of your regular conversation at these visits.
Yeah. That is great advice for everyone. And I know you both have given us a lot of passion and tools and education that I know we're going to take forward in our work. So I just want to thank you both, Kim and Dr. Reggie, for being with us today and helping us with our work. And next, or pull the slides back up. And thank you again. And if you have any further questions, feel free. I think Kim and Dr. Reggie, we have about 7 more minutes. We'll be here to kind of respond. All right. As I mentioned, Christina Turpin, Director for the National HPV Vaccination Roundtable, and I'm happy to be here with you guys today. Next slide. So we've talked about the presumptive recommendation, motivational interviewing. Tell us, how do you plan to incorporate them into your work with our post-session poll that we're going to pull up? And we'll give you a few moments to do this. I think everyone's reading, nothing in yet. Some answers are coming in. It looks like there's some, I would like to combine approaches, plan to use presumptive announcement approach as routine part of all vaccine conversations. Great to hear. Not sure how to apply them yet, which is okay as well. That's why we're here. That's why we have resources. And that is why this is the first part of a communication series. So there'll be more conversations around this. I'm going to give it a few more moments for response. All right, it looks like the most we have here for a combined approach. A little bit more. All right, can we end the poll and move to next slide? So I'm going to give a few resources today to help you guys with your work. So first would be our landing page that we talk about in every session. And so anything you might need can be found on this landing page. So this is where we have all the resources shared, and we at the top of the page under important links, you can see here our recordings, slide decks from all of our sessions from both 2024 and the ones we've had already in 2025. Next slide. And we've also put together tools and resources to support the learning from today's session. So you can access all our resources via the roundup, and you can find it in our website under important links. The document is regularly updated, so we have things from today. And if you have a resource that you want to add to this, just reach out to myself or Ashley and we can make sure to add it. Next slide. We want to highlight two resources today that are new and can support with communicating the HPV vaccines to patients, parents, and providers. The first is the ACS Social Media Toolkit, which is ready-to-use graphics, messages, and resources tailored for year-round outreach in both English and Spanish. It's perfect for all types of health systems, clinics, community partners who want to engage audience with accurate and impactful information. So there's plug and play posts, friendly messaging, visual appeal, optimized for a variety of platforms. So it provides tips and tricks to optimizing social media messaging across different platforms. So we're going to add that link into the chat for you. Next slide. And then additionally, I wanted to share our HPV Communications Toolkit, originally made for health plans, but has resources to help all health system partners communicate with providers and patients about the importance of HPV vaccination and encourage initiation at age 9. First set of tools are for direct outreach to providers, and the second set of tools are ready-to-use resources to use with patient outreach. And that is also added into the chat as well. And as always, we hope that you take this information from today and implement changes into your daily work or organization. So our call to action today includes evaluate your personal communication style and set a goal to apply what you learned today. Try a new way to educate and promote HPV vaccination. Make a strong HPV vaccination recommendation at every eligible visit to a patient 9 or older. Explore strategies and resources shared during today's session to educate and train your teams on the announcement approach or motivational interviewing. And then for August, compile a list of HPV vaccination myths you have heard in your clinic or community. Next slide. And I just want to thank you all for being here today. And we look forward to seeing you for August session where we'll continue our summer communication series and start addressing HPV vaccination hesitancy. Thank you.